Hi, Doc.
Hello.
Hi. How are you, sir?
Thank you for the invitation.
Thank you. Thank you. Uh, Pleasure is all mine. Uh, shall we start, sir?
Yes, we can start now.
Yeah. Yeah. Sir, if you don't mind, can you please introduce yourself to my audience?
Okay. So my name is Humberto Arrue. That's already my last name in Spanish. In English would be Arrue. I'm an orthopedic surgeon, fellow shoulder fellow and sports medicine. I'm the president of our national uh, shoulder surgery and elbow association. I've been working for 21 years as an orthopedic surgeon in a private system. Uh, I have also faculty from Artrex Latin America since 2010. I've been a trainer for the ANA, which is the Arthroscopic American National Association for Latin America as well. So I'm very involved in the technology, in the last techniques, and to teach other doctors in Latin America uh, all the shoulder procedures, especially the minimally invasive procedures. So I'm glad to be here and accept your invitation. It's my pleasure and flattered for that. So I really appreciate it.
Thank you, sir. Thank you. So, where do you practice? Which country, sir?
I practice in Panama City, Panama.
That's
Panama, it's a well-known country because of the Panama Canal. But
Panama
we are
Canal. Yeah, yeah.
exactly. But we're also proud to have one of the best medical system in the whole Latin America, and we're considered one of the best places for retirement for European and American people. So we're
Really?
proud of it.
Okay. Nice, nice. So, shall we start, sir?
We can start now if you wish.
Yeah. Sir, I would like to ask you, like, if some athlete comes to you who had a history of some injury or sprain while bowling, so how frequently you advise an MRI scan? So, what is your criteria?
Yes, I always every day I receive patients from sports injury. The most frequently injured that I've seen, it's rotator cuff and labral and superior labral injuries because of practicing baseball, softball, fast pitch, CrossFit, tennis, and we're now heading like an explosion of paddle, which is it's also it's a racket sport as well. So it's very popular and addictive as well. So so this is the most frequent injuries and patients that I've seen, and I've seen every day. Every day it comes here in my office.
So, when do you advise an MRI scan?
Come again?
When do you advise an MRI, magnetic resonance imaging scan?
Yes, we recommend always a magnetic resonance. We always recommend a good one because there's some cheaper magnetic resonance, but we recommend the 3 Teslas magnetic resonance because it's really hard to see or to evaluate a patient, especially if it's in sports. And here in Panama, the baseball is it's a major sport. It's also like a way of be out of the poorness, because mostly of the baseball player come from poor areas, and they wanted to practice sport to get a like a bonus or for just for signing, and they play professionally, and sometimes just their trainings or the parents bring us those players with a very poor magnetic resonance, and sometimes we recommend to do it again. So I always recommend a good magnetic resonance. It's totally different. It's a like a game-changing stuff if you want to evaluate in a good way a patient.
So in the MRI, if there is a partial tear, so will you, what do you suggest? A steroid injection or a surgery? What do you tell?
You mean to any kind of injury in special?
Partial rotator cuff tear,
Oh,
partial supraspinatus tear.
okay. So we follow the Elman classification, which is it's divided in three areas, in two major. We have partial articulate tears and dorsal tears as well, and we classified into the class one would be, or type one would be less than 3 millimeters. The second type would be 3 to 6 millimeters, and more than 6 millimeters, it's the other one. If you have a partial thickness tear of your rotator cuff less than 3 millimeters, we don't recommend to do anything, just debridement, and use radio frequency to burn it out and to stabilize the fibers. Then if you have 3 to 6 millimeters, that will depend if it's a female. We and not a sport lady. We can leave the tendon like this because it doesn't normally it doesn't move. It's more than 50% of the thickness of the insertion of the tendon. And if, of course, if you have a more than 50%, like an L13, we recommend to complete the tear and do a speed bridge, which is a two-row system that I've always proceed with that. If you have a dorsal rotator cuff tear, it's you don't want to have that or to leave the patient with that. The dorsal area is the strongest part of the rotator cuff. So if you have more than 3 millimeters, it's better to repair it. Yeah.
So no role of any steroid injection. No steroid injection.
Well, I normally don't do steroid injection if you have a partial thickness tear of the rotator cuff, because the steroids is well known that that may decrease the strength of the fibers. So I just infiltrate cortisone just in case the fibers are inflamed but not torn. If you have a torn rotator cuff, it's not recommended to do steroids.
Okay. So what is the difference between a bursal tear and a articular surface tear?
Well, actually, partial thickness tear at the articulate surface are more tolerable than the dorsal side. Normally, you can if you have a very small tear, less than 1 millimeter, then you can use steroids, and of course the patient should be involved in that situation, because if you put cortisone, you may decrease the strength. So the patient must be aware of everything and all the risks that you can have with that. I don't know if that's a question if I answered the question.
Yeah, basically we treat bursal tears more. We give more attention to the bursal tears when compared to the articular surface tears. That's what they tell, because the bursal tears, they give a lot of pain. They continue to progress, and
Yeah.
they might get converted into a complete tear. So
Yeah. And actually, if you have a partial thickness tear at the dorsal side, it may be involved with the acromion. So if you have a grade 3 acromion associated with the dorsal tear, normally it's like a mirror. It's a mirror injury. So it's recommended not only to repair the tear, but do the acromioplasty as well.
So, what is the meaning of acromioplasty, like according to you? Like, how far you clear the acromion?
That's a good question. First thing, most of the sports medicine doctors don't believe in the acromioplasty.
Yeah.
I am formed. My teacher, my master, who passed away this year, is Dr. Charles Rockwood, and he taught me how to do the acromioplasty, and I use the same criteria, but arthroscopically. And there's an old story that's saying that or reported that if you
Rockwood means he's the author, textbook.
yeah, exactly, the two textbooks.
Really?
Yeah, that's Dr. Rockwood. Yes.
You got trained under him?
Yes.
Wow, great.
San Antonio, Texas. Yes, 2001. I was the
Where?
time of my fellowship. Yes.
Where? Which country?
USA.
USA. Wow, great, sir. Really?
Yes, and he taught me to don't go farther than 4 millimeters of the chromium, exactly where the deltoid raphe is. So normally I'm just cutting off until I see the raphe of the deltoid. Once and of course I use the bore. It's a 4 millimeter thickness. So exactly once I reach that size, the raphe, I just stop to cutting off, and I just do the line, and then I move the arthroscopic, the camera. I put it in a lateral portal, and just finishing trying to reproduce a grade 1 acromion. That's what we wanted to do, and we wanted to have. We normally, when we treat full thickness tear of the rotator cuff, there's a acromion grade 3. So we want to change that grade 3 acromion into a grade 1 acromion, which is flat. And we always do that. And normally you must have to do in two views: posterior view, cutting off the spur until you have the 4 millimeters at the raphe, and then move the camera to the lateral, and reproduce the flat shape of the acromion, and to get to a grade 1 acromion.
How common is the fracture of acromion? Are you not worried of the acromion fracture?
It's pretty rare. To tell you the truth, I have more than 2,000 shoulder arthroscopy in my whole career, and I haven't seen one. No fracture of acromion after any acromioplasty. So you want to remove the tip or the spur. You don't want to structurally affect the acromion.
Okay. So you do bursectomy and you do acromioplasty.
I always do
All cases.
all cases the subacromial decompression, which is mean that removing all the chronically inflamed bursa. The bursa, it's like a veil. It's a very soft veil, but in those kind of patients, the bursa becomes very thick and painful and needed to be removed. And I just removed the part of the AC ligament associated with the spur, but I don't release it all. And then the acromioplasty. That's part of the procedures that I perform when I do a shoulder arthroscopy.
So people they tell they don't touch AC ligament. So what is your opinion on that?
Yeah, I just remove exactly the ligament that it's underneath the acromion, because I needed to remove it. Otherwise, I cannot perform the acromioplasty. So I always remove just the part, the anterior part, because we don't want to have escape of the humeral head anteriorly. So I left that ligament with no problem.
So some surgeons, they do convert partial tear into complete tear and they repair. So what's your opinion on that? Have you ever done that?
Yeah, it's you have a more than 50% of partial thickness tear. I complete it as well. I hope sometimes, or in some patients, younger patients, I'm talking about 40 under. If you have a partial thickness tear, I don't complete it. I just perform a pasta bridge repair, which is to put 2 anchors in the insertion, right at the articulate margin, and then the tied knots between them, and then like a triangle, get 1 suture of 1 anchor, and then do the triangles, the lateral, and fixing the sutures in the lateral side of the humerus with swivel lock. So it compressed it's like a transtendon repair. It's doing exactly, it's very similar when you perform the remplissage, when you do on stability in the group, in the number 2 group of Burkhardt. So it's exactly the same, and I just perform that way in just younger people. Normally, when you have older people and more than 50%, I always complete the tear and then do the speed bridge repair.
So what anchors you use? Metal anchors or peak anchors?
The anchors that I'm using, and I've been using it for 15 years, it's swivel locks. Swivel locks from Atheletes. Yeah, swivel locks from Atheletes, and it's a 4.75 millimeters thick. So that's the one that I just performed.
So all four, I mean both the medial 2 anchors and lateral 2 anchors, lateral 1 anchor.
Exactly, but sometimes the tears include the infraspinatus tendon, and sometimes you need to expand that repair, and the supraspinatus and the infraspinatus insertion are mixed. They're conjoined, and but when you have a horizontal area exposed, you can use the 4. But once you have the posterior insertion exposed, you need to put an anchor over there. It means that at least you need to put 3 anchors in the medial row and 2 anchors in the back, or 3 anchors in the back, expanding the bridge. The most expanded bridge that I perform, it's 10 anchors, 5 in the middle, 5 in the lateral side. It's a very massive tear, including the teres minor tendon as well. Yeah.
10 anchors.
Yes, 10 anchors.
The government is paying or patient is paying?
The patient was, it's like a 6 feet tall, and he was 68 years old at that time, but it was a traumatic tear. So he falls down from going downstairs, and then he, tried to hold his head with the hand, and then torn all the rotator cuff, everything. Have totally with a pseudo-paralytic arm as well. So
what is your opinion on massive cuff tear? You do superior capsular reconstruction, or what do you suggest?
Well, that's very interesting, and I've been part of the SLART, which is Latin America Sports and Knee and Shoulder Association, as a committee to recommend the treatment, and it's different if you set massive rotator cuff or irreparable rotator cuff tears. So if you have a massive rotator cuff, it may be repairable. If you have a massive rotator cuff, it means that your torn it's 5 centimeters away from the insertion. And as Dr. Burkhardt said to me one time, he told me all rotator cuff tears are repairable until you cannot repair. And it sounds like simple, but it includes that no matter how far it's the insertion or the tendon, if you can repair, it's better to repair it. If it's it's a unrepairable rotator cuff tear, and then you need to choose what exactly is the procedure that will work best for the patient. And in that situation, if you have the couples, like normal couples, and I said it's subscapularis along with the infraspinatus tendon, those couple of strength may work with the superior capsular reconstruction. But if you have it means that if you just only have an irreparable supraspinatus tendon, you can perform a superior capsular reconstruction. If you have a posterior superior rotator cuff tear that the infraspinatus is involved, and it is not repairable, to perform a superior capsular reconstruction, it will fail. So the treatment that I have chose for that in that situation, it's the transfer of the inferior trapezius tendon along with the Achilles tendon allograft, fixed by two swivel locks over the top of the and anteriorly to the footbridge of the supraspinatus tendon. So those are
Lower
the.
trapezius transfer.
Excuse me.
So you do lower trapezius transfer.
Yes, absolutely. Yes, it's not frequent, but I've done it with good result as well. So if you have a massive or an irreparable subscapularis tendon, so you have two choices: whether you can use the major pec to transfer the major pec tendon, or to perform the latissimus dorsi tendon transfer as well. Yeah.
So out of all these injuries, which injuries are common in athletes? Cuff tears or instability?
Yeah, rotator cuff tears, yes, are common, but those kind of tears, like massive tears, are not common because normally when you have a patient, it just like a whole their symptoms and don't want to go to the doctors, or sometimes what I've seen is some doctors here in Panama, and it happens in the whole country, they just recommend physiotherapy and don't, you should be in the area. I don't treat much feet. I don't do backs. I don't do hips, or especially arthroscopic hips. I just recommend to doctors with that because I want to be at the tip of the arrow. I want to be on top, and that's why I just do the best scenario for the patient. And sometimes some doctors see shoulders and they don't like. I would say that they're not training in that area, so the recommendation won't work well for the patient at the end. So normally those kind of tears, like an irreparable massive tear, are pretty rare in my private practice, yes.
So, for example, if you have done a rotator cuff repair and the patient is not getting any movements after surgery for 2 months, so how do you proceed?
You mean if I do surgery for one patient?
Yeah, one patient, we have done surgery. We told to go to physio,
Okay.
and the patient was not on physio. And after 2 months, he came with a stiff shoulder.
Wow. Well, normally, and that's a good question because Dr. Rockwood taught me not to send all patients to physiotherapy, and I just I teach them like a home program, and it's with the pulley and stick exercises. And you can check into my Instagram profile, and you will find them how to perform the stick or bat exercises. And I just because the experience that I have with physiotherapy is that shoulder as you know, shoulder, it's a very special joint. So
Yeah.
if the physiotherapy is not training in the shoulders well, it may be the problem with the patients of the shoulders. So so it may tear the patient or stiff the patient, may produce a stiff shoulder as well. And when the shoulder got inflamed, it got stiff and got stuck.
Yeah.
And it depends. And so that's why I normally receive patients with adhesive capsulitis or frozen shoulders, but it's not too frequent to get a patient with a frozen shoulder after surgery, because normally I do the follow-up in 3 weeks or 1 month or monthly. And then when the patients came to my office with some stiffness, it means 2 things: whether the patient is afraid to do the exercises, or he's just don't want to do the exercise. He's lazy. The patient is lazy.
Yeah.
So I encourage them to do the exercises, to proceed with the program otherwise needed to be operated again. And if I tell you in my more than 2,000 shoulder surgeries, I've just performed a capsular release after a rotator cuff repair in just only 2 patients. So normally the patient, once I just informed about the potential surgery because of the stiffness, he says, "Oh no, doctor, I will do the exercises right away," and then then the next visit it's get the normal range of motion.
So it is not very common. I think out of 2,000 surgeries, only 2 patients you reoperated for a stiffness post cuff repair.
Exactly.
What is your protocol after cuff repair? You put him in an abduction splint or not?
No, well, just when the repair is very tight, and I need it to be stretched. If I stretch a lot the tendon, I have the abduction pillow along with the sling, and it's more comfortable for the patient. But my experience, whether if you use it or not, it's just for comfort of the patient, not to avoid a re-tear of the tendon, because but it's more comfortable for the patient to have a pillow. The bad thing about the pillow is that we're a tropical country, and if you're not in the air conditioning, you will suffer that. It will produce a lot of heat. So, but it's more comfortable for the patient. And yes, I use this. I use it not too frequent, but I tend to use it when I need it to. When it's a massive tear that I could repair.
So coming to the cuff repairs in elderly, so what's your opinion on biceps tendinitis? So you do biceps tenotomy or tenodesis?
No, actually, I'm changing to those kind of patients. So I have a protocol that I would like to upload the paper, and patients older than 70 years old, I tend to do a lateral transference of the long head of the biceps, because I want to integrate that tendon to the repair. Because as you know, the structurally the rotator cuff of those elderly patients has diminished and needed to be like a reinforcement. I use the biceps, so I just release the tendon from the bicipital group, and I perform with the board another sulcus, a lateral sulcus. So I just move the tendon into that lateral sulcus. I use a biceps swivel lock to fix it, and then I do the repair. So it's a kind of superior capsular reconstruction using the long head of the biceps, and then I have the rotator cuff repair. And so in that, using that kind of technique, I have no patient with a re-tear of those kind of profile, older than 70 years old, and the pain post-operative, it's much less. And normally those patients get normal range of motion just in a month or in a month and a half. That it's not normal as well. So I'm glad to use that procedure. Hopefully, I have performed like in 10 patients. So I hope to get more to publish that study.
So you don't do biceps tenotomy?
Yes, I do, but normally it's in younger people. Tenotomy it's indicated for patients older than 40 years old. Otherwise, if you have a slap tear, needed to be repaired anatomically. So normally, if you have a slap tooth tear with a rotator cuff tear in a young people, as I told you, less than 70 years old, I tend to do the tenotomy, and I always do the tenodesis as well. And I do the tenodesis at the articular margin using a biceps swivel lock.
So you mainly do tenotomy for old patients and tenodesis for young patients.
Yes.
Okay. So out of instability and cuff repairs, cuff tears, which is common in athletes.
Yes. Yeah, and it's all, normally the younger people has more labral tears than rotator cuff tears, or they have both, but the kind of tears of the rotator cuff are just like a fibrillation. It should be like an Elman grade 1. So it's just a debridement of the tear, and that's it. Debride and go. And treat the labral tear as well. If you have a slab 2, needed to be repaired anatomically, and or the posterior or anterior inferior labrum as well needed to be repaired.
Okay.
Patient's call.
Yeah, I think 1 minute. Chepu. ప్రాక్సిమల్ టిబియా అన్డిస్ప్లేస్డ్ ఉంది కదా.
No problem.
నడుస్తున్నాడా? అయితే అది ఓల్డ్ ఫ్రాక్చర్ ఏమోరా, నథింగ్ టు డూ. ఏం కాదు. పల్స్ బాగానే ఉంది కదా, నో డెఫిసిట్స్. సరే, ఏం కావాలి. లిగమెంటస్ ఇంజురీ ఇలాగేం డౌట్ లేదు కదా. సరే,
Duty calls, no problem.
So, coming to the very important aspect, through which clinical tests you differentiate cuff tear and periarthritis or adhesive capsulitis in the clinic? Which tests you would do?
Well, actually, when you have an adhesive capsulitis, it's all motions are diminished and painful. It's like it's a painful rigidity of the shoulder, so you cannot move freely, and in that's the difference between adhesive capsulitis and the rotator cuff tear. So you may have a massive rotator cuff tear with a pseudo-paralytic shoulder, would it seems to be the same, but when you hold the hands of a pseudo-paralytic shoulder, you can move freely with no problems and no pain. So it means that it's when you have a frozen shoulder, your shoulder is stuck and painful, and with no even if you use general anesthesia, the patient should be stuck at the OR. So we in that case that's the difference. Another difference is that when you even with a very severe adhesive capsulitis, if you test the strength of your rotator cuff, normally the strength are normal because adhesive capsulitis comes with a partial thickness tear of the rotator cuff, which means that the joke test, for example, the infraspinatus test, the lift off or the belly press test should be normal. In the other hand, if you have a massive rotator cuff tear, that tear will be negative or no tension at all in the patient in the tendons that is involved with the tear. So adhesive capsulitis, it's very easy to diagnose because patient is stuck and painful.
Okay.
Yeah.
So what structures you release in adhesive capsulitis?
What I do?
What structures in this capsular release?
Yeah, we adhesive capsulitis has 3 stages, and clinically you may have a mild, moderate, and severe adhesive capsulitis. So if you have a mild adhesive capsulitis, we recommend just to perform the home program, anti-inflammatories in case that the pain bothers, and then avoiding any active, any strength motion or using or force your arm or your shoulder to use. In case it's moderate, we can give a cortisone shot. If the pain is subacromial, we can do that subacromically, or if it's more the joint, we can put the cortisone into the joint, and then teaching the shoulder program and anti-inflammatories. In case of severe capsulitis, and for me, severe would be less than 90 degrees of anterior flexion, the internal rotation exactly at your butt, or in the external rotation less than 10 degrees exactly. So we recommend surgery for that. I recommend surgery because it's
So
very
what structure you release arthroscopically?
yeah, it's a 360 degrees release. We perform that arthroscopically. We cut out all the insertion of the capsule of the subscapularis, the rotator interval. It needed to be cut as well, and above the origin of the supraspinatus tendon needed to be released as well, and it's above the labrum, the superior labrum, and then we put the camera and the anterior portal, and then release all right all the way in the back, the posterior capsule. At the position of the 6, normally I don't touch it because the artery and the nerves are just very close, and in every patient with severe adhesive capsulitis, the thickness of the capsule, it becomes very thick and close to the artery. So I just do the manipulation, and then I put my camera again, and if there's some fibrillation, I just remove it and I use the radio frequency to stabilize those fibers. That's what I perform.
So you release coracohumeral ligament also?
The what? Excuse me?
CHL, coracohumeral ligament.
Okay. Well, coracohumeral ligament, I normally don't release it. It doesn't need it to be released in my consideration.
So you release the entire capsule,
yes.
Rotator interval.
Yes, and then once and of course, sometimes adhesive capsulitis, it's not it's secondary to something, and if you have a small tear, it needed to be fixed as well. And once I just put my camera in, I just check the subscapularis tendon, the supraspinatus tendon, the infraspinatus tendon, the biceps tendon, the labrum, and if you have any severe synovitis that needed to be removed. But once I fix everything inside the joint, I put my camera subacromial space, and normally they have adhesions outside the joint, so it needed to be removed as well.
So, yeah, coming to the subscapularis tear, how frequently you see it, and what is your criteria to repair?
Well, actually, it's very frequent to have a subscapularis tendon, and normally those tendons are not visualized in as easy as should be for the supraspinatus tendon. So you need to look at the insertion of the subscapularis tendon. And to tell you the truth, I would say that 30% of the rotator cuff of the supraspinatus tendon tears comes with along with subscapularis tendon tears as well. So normally the kind of tear, it's Lafus or Romeo grade 1, which is if you have more than 4 millimeters separation or tear of the supraspinatus tendon, subscapularis tendon, I normally fix it. So because if the swivel lock, it's 4 millimeters wide, if I find something like the thickness of the or the wideness of the anchor, I rather just to fix it, because otherwise it will keep tearing and it will increase the tendon, the tendons tear. So I fix it using the speed fix technique, with there's only one suture, It's like an inverted U. So we pass the sutures and then fix the tendon. It's a very strong and helps me out with the patients a lot.
Nice, sir. Nice, nice, nice. So, how many surgeries you do approximately in a month, sir?
I I I do 3 to 4 shoulder arthroscopy per week, which is mean like 10 per month, more or less. Yes.
You do only shoulder or a knee also?
No, I do knees as well. I would say that 70% of my procedures are shoulders, 25% are knee arthroscopies, and then the 5% is the rest of the work.
Yes. So, do you have any fellowship program under you?
Excuse me?
Do you have any fellowship program under you?
Yes, actually, I'm proud to say that I'm the first doctor here in Panama to receive a fellow from another country. Normally, we fly away from Panama to get trained and then go back. But when I was invited for the El Salvador's National Congress, one of the doctors wanted to come with me, and he stood with me. He stayed with me 6 months in a fellowship. So I have a fellowship, and I needed to get the permissions for our Ministry of Health, and I was allowed to do that. And it was the first time that I formally trained a fellow, and I'll be receiving another fellow from Guatemala, and he's training right now at Brazil, at Argentina, and then wanted to be with the Panamanian guy here and to practice. So I'm involved in that situation. Yes.
So, I think can someone can come to you and do some short observership for 1 to 2 weeks like that.
Yes. Yes, they can observe, but normally I just it's better not only to observe, but put hands on it as well. So that's when we want to get when I will receive a fellow, I just rather to write to our Ministry of Health. So he wants just to join with me at the surgery, because he may hold the camera and feel the screws and everything. That's more. That's better. That's better.
Nice, nice, nice. So thanks, doctor. I'm very thankful to you. So we discussed so many things. So
Yeah.
what are the other common injuries in athletes? Other common injuries
Well,
other than cuff instability.
yeah, I do everything in shoulders. My fellowship was shoulder, and I've done cancer surgery, destructive and transference of some muscles, fractures. I'm not on call at any ER hospital, but sometimes just the people call me because they know that I'm a shoulder doctor, and I do trauma for shoulder trauma as well, and but mostly it's all shoulder problems. In frequency would be rotator cuff tears. That would be the number one. Second one, it's shoulder instability. Third one will be slap tears. Four would be AC joint problems. And then the rest of the time, I like a prosthesis as well. I perform shoulder prosthesis, whether it will be anatomic prosthesis or reverse shoulder prosthesis, hemiarthroplasties. That's my like the most frequent procedures that I perform. Yeah.
So when do you do a slap repair? What's your criteria?
Well, actually, yeah. First thing is that slap tears are difficult to diagnose, and sometimes are under or over diagnosed, because they have some morphology of the labrum that may confuse, or sometimes the tear is so easy to see, but the doctors, and that's another difficulty that we have here in Panama. We have just only 3 doctors specialized in musculoskeletal system, 3 radiologists, and sometimes the doctors get a course. The radiologists do like a informal course, and they try to do the reports, and they miss the diagnosis or overdiagnose. The most important thing is that when we have a patient with a O'Brien test positive, which is for me, it's the most important test for slap tear. It's O'Brien. You may have a patient with a O'Brien test positive and maybe a false positive, but you will never have a patient with a slap tear with a negative O'Brien test. That's very important. Okay. That's very important to know. So if I have a patient, especially if I have a young patient, I receive almost every day a picture from a little league, like a little league pitcher, or a very young pitcher, which has a slap tear seen at the MRI, and if that patient, and normally I don't recommend surgery at first, I put into the physiotherapy program, strengthening the periscapular muscles, changing a little bit of the overhead motion, and I'm going to show you. All pitchers wanted to reach right in the back to throw faster, but you can do it in a wrong way and in a good way. If you forcefully externally rotated your shoulder, it may produce a slap. So that's not recommendable. What we recommend is to close the scapulas. And if you can see, I'm keeping the patient plane and closing my scapulas, and I don't force my shoulder into a bad external rotation. And you, as I'm telling this, there's a lot of instructors that don't know how to teach this technique for the pitchers. And of course, if you have a slap tear in the pitcher or overhead sport player, you will develop GERD, and GERD is a glenointernal rotator deficit. So once you perform once you throw the ball or the javelin or whatever, all patients with slap tears has a decreased internal rotation. Should be like this, but normally they end like this, and it's because they have a huge external rotation and a bad internal rotation. So it's because you're overstretching your anterior capsule. So at the end, I have this patient with that profile. I teach them how to increase the stretch of the posterior capsule, do the periscapular strengthening, take physiotherapy, take medications. But at the end, if the O'Brien test is positive or it's still painful for more than 3 months, I recommend surgery to fix it. And if I fix it, the way I fix it is using a 2.9 millimeter push lock with fiber wire, with number 2 fiber wire. That's the way I treat it.
So how many anchors you put?
Depends of the kind of the size of the tear. Normally, we put 2. It's normal because normally the peel off mechanism tend to tear not only the biceps but the labrum as well, and you need to fix one of the top at the 12th position of the plaque, and then 11. But if you need to put whatever anchors needed to fix the whole labrum.
So usually you put around 2 anchors.
Yeah, no, usually 2 anchors, yes.
So what is your post-op protocol for slap repairs?
Well, it's exactly that any rotator cuff tear. Normally, the patients I tend to put into the home program, and I send it to rehabilitation after 1 month and a half, because it's more fixed than lose the structure. I don't want the physiotherapist to tear my surgery. But normally I need to put my feet on the brake pedal because they recover too fast. there are young people with the normal rotator cuff, and they want to like their anxiety to throw and to start everything. It needed to be controlled. So I just I tried to hold them, and after 3 months, yeah, and the procedure is control the pain and then get the normal range of motion. And when I said normal range of motion, it includes the ABER precision for throwing, exactly. And then strengthening the rotator cuff with TheraBands or rubber bands. And then after 3 months, I sent them to the gym to increase the strength of the periscapulary muscle and start the throwing program. The throwing program is very important because I want to change the mechanics into when we were talking for avoiding the over external rotation, but closing the scapula to throw better, to use more the back, exactly. And then the throwing program is for that condition, to change a little bit the mechanics. And it'll take like a month, the throwing program. And normally the patients that has tears are pitchers. So the throwing program started at 30 feet away from the catcher. But at the end...
After 1 month? After 1 month of surgery?
Yes, after 3 months.
3 months?
3 months, yes. And then it started at 30 feet, and then will be 5 feet in the back every day until they reach 180 feet. Once it's too long, I know, but once they reach 180 feet and throw with no pain, they can do bullpen, which is now practicing the whole mechanics with a catcher kneeled, with a kneel catcher. So once they get that point with no pain, then they can play with any problems.
So immediately after surgery, you do the movements.
Yes, yes.
But throwing after 3 months.
Yeah, the throwing program is after 3 months. So the labrum takes 3 months to heal. So I want to start the program, the weightlifting program and the throwing program once the labrum is totally healed.
So do you do any repairs of posterior labral tears also?
Yeah, of course, because as you know, the labral tear are divided into A, B, and C. And A, it's anterior, B, it's top, and C is posterior. And normally when the peel-off mechanism tear in the back. So sometimes the slab comes over the top, crosses a 10, and then maybe into 9 or 8. So it needed to be fixed. It needed to be fixed. That's why I told you that all anchors need it. And sometimes we have and actually we have a patient with that needed to be repaired, the whole stuff, the 360 degrees of the glenoid needed to be fixed. Well, unless the anterior superior labrum, don't touch it. Otherwise, you can produce a lack of external rotation of the patient. So don't touch the anterior labrum. So if we're treating a right shoulder patient, never fix between 12 to 3. Never fix. Fix just over the top of the biceps, the labrum over the biceps, and then the back of the biceps, the posterior labrum, the posterior inferior, anterior inferior until 3. So no anterior labrum, anterior superior labrum needed to be fixed. Otherwise, you can produce a lack of external rotation of the patient, or a painful external rotation that will be exactly the same.
So for the right shoulder, 12 to 3 o'clock. No
fix, never fix it. Because sometimes you can find a patient with a Buford complex, which is a normal morphology. It's a variation of the anatomy, or you may have like a sublabral hole, which is normal as well, and the shoulder works with no pain. So I've never fixed it, and I've done it for more than 50 years. So once I start the whole stuff for fixing, so don't touch it.
Nice. So we had a great discussion, sir. I think we'll join once again.
Absolutely. Thank you for the invitation.
Shala, thanks. I'm very thankful to you. If I come to Panama to see the Panama Canal and all, I'll definitely come to you.
You have a friend here, and I will take care of you in a good way. So just let me know when you want to be here in Panama. We want to have a breakfast, a dinner at the Miraflores restaurant, which is just it has a balcony just next to the ships that coming from the canal. So you will see that in 20 meters away from the ship. It's an excellent experience for that.
For 2 days visit, I will come and assist one surgery also.
Of course. Of course.
Okay, please talking to you, sir. Yeah. Nice
So-
talking to you. We'll join, we'll come together. We'll see. I think I'll come by this year ending, maybe. I don't know.
Well, I'm glad to take care of you. So if I want to be at India, of course, I will let you know for sure.
Anytime, please come. Hyderabad biryani you can have. Charminar you can see. There are so many things here you can watch. Taj Mahal in Agra. Beautiful temples are there.
Yes, of course. That's a very special.
If you see the temples, you will get the mind
Really?
shock.
Yeah.
Great architecture, 1,000 years, 2,000 years, 3,000 years old temples are there.
Wow. That's impressive. I've seen just in pictures, and it impressed me every time.
Please come. I am
Yeah.
there. I'll take care of you.
Thank you. Thank you for the invitation. I really appreciate it.
Thank you.
Bye-bye. Take care.
Bye bye.